My pleasure to be back in SWAR's giving presentation of a retina guy in anterior segment meeting. Actually, my first presentation I presented was 30 years back at SWAR's. My talk today is macular edema after cataract surgery. Perhaps the first who described the macular edema following cataract surgery was Irvine in back 1953, and he named it as a vitreous syndrome following cataract surgery. And this was attributing that the cause of this macular edema is totally mechanical. In 1966, Gus described the clinical features of this edema, attributing with the fluorescein angiogram changes of this macular edema, and hence the name was Irvine-Gus syndrome, with the characteristic petaloid appearance in fluorescein angiogram and hot disk. Actually, if we classify the macular edema, we can get angiographic cystoid macular edema and clinical macular edema. And in angiographic, it is totally asymptomatic disease, and clinical macular edema contribute to acute, late onset, and chronic and recurrent. Actually, the incidence dropped with the innovation of the phacoemulsification to 0.1% to 2.35%. Actually, what happens is that inflammatory mediators due to cataract surgery travels to the macular area, causing eosinophilic transudate accumulating in the outer plexiform and inner plexiform layer, forming cystoid spaces. Actually, with the advance of the OCT, we're able to have a full-through image, knowing that there is a premacular bursa. And this premacular bursa has a septum at the cloacae canal. It is present in 80% of cases. 20% of the cases you don't find this septa, and hence the problem comes from. Picky known using ENFAS and high definition OCT, known that in uveitis, the pathway to travel from anterior to posterior segment is the absence of this septa. So if you have a patient doing OCT for this patient, you will have clearly show the septum, which is present at the premacular septum. Risk factors for development of this entity is usually complicated cataract surgery. So avoid vitreous traction at the incision site, clearly do anterior vitrectomy, leaving no vitreous at the AC, as it precludes the cystoid macular edema following cataract surgery. Also, the iris-fixated intraocular lens increase the risk of developing post-operative cystoid macular edema. Another important issue is the presence of systemic diseases can contribute to post-operative macular edema like diabetes, uveitis, glaucoma medication, or vein occlusion epiretinal membrane. The diabetes mellitus shows that there is 1.8 times risk to develop cystoid macular edema even without pre-existing macular edema in such cases. And the previous pan-retinal photocoagulation did not appear to prevent this event. There is an argue whether to do prophylactic intravitreal anti-VEGF. The PROMISE trial have answered this question, saying that there is no value of pre-operative intravitreous injection for cases to prevent post-operative cystoid macular edema. On the other hand, if you have a pre-cataract surgery cystoid macular edema, it should be treated promptly before going into phaco surgery. You should dry the macula totally, and then you go for the cataract surgery. Another important issue is the uveitis issue. In the past, the uveitis was contraindication to do cataract surgery. But nowadays, we do cataract surgery in uveitic patients. But take in consideration that corticosteroid is mandatory in such patients, and you should use prolonged acting corticosteroids for a long time post-operatively. Another important issue is that it is forbidden to do cataract surgery unless the patient in remission for at least 3 months prior to cataract surgery. There is a debate about glaucoma medications that whether induce macular edema or not, but recently, if you stop this medication, the macular edema will subside down if you have it. The diagnosis have the characteristic picture of the fluorescein angiogram with early perifoveal leakage and late petaloid appearance together with the hot disc. Another important issue, you find cystoid spaces at the outer plexiform and inner nuclear layer, and later on this fluid escapes to the subretinal space. Is it mandatory to go for OCT before going for cataract surgery? This study answered this question. They found that in doing pre-cataract surgery, OCT, you can miss up to 23% of macular edema undiagnosed if you depend only on your clinical sense. And you underestimate in 3.2% of cases of cystoid macular edema. And they recommend, when you can do OCT prior to cataract surgery, go for OCT prior to cataract surgery. You may find surprises. What is the prophylaxis of this cystoid macular edema following cataract surgery? Number 1 and 2 and 3, avoid intraoperative complications. Go for smooth surgery so you decrease the incidence of the cystoid macular edema following cataract surgery. Another important thing is that the use of non-steroidal anti-inflammatory prior to cataract surgery decrease the incidence of cystoid macular edema following surgery. And you start it few days before surgery, and you maintain it in high-risk groups up to 3 months on non-steroidal anti-inflammatory drugs. And the treatment, first line of treatment is the topical non-steroidal anti-inflammatory drugs. And whatever the drug you are using, it works. But newer drugs like nipafinac and promofinac have a deeper penetration power. And the power to penetrate to reach the retina is 4-folds than the older drugs. Another important issue, combining corticosteroid to topical corticosteroid to the non-steroidal anti-inflammatory agents increase carry better prognosis for such cases. Steroids, we can use them periocular and even intravitreal in resistant cases. With the advance of the new dexamethasone implants, lower the complications of the old triamethylone acetanoid drug injection. There is controversy about using anti-VEGFs in such patients. Some say they improve the condition, and others say they have no role at all. And also, oral carbonic anhydrase inhibitors carry the same equivocal effect, and it does not carry better visual prognosis on long time. Important issue, if you find vitreous stuck into the wound, please try to cut it with YAG laser, leaving the anterior chamber free from any vitreous tags. And lastly, in very resistant cases, we resort to surgical treatment with pars plana vitrectomy. Thank you all for your attention.
much, Dr. Tarek. You told us about angiographic cystoid edema following cataract surgery and clinical edema following cataract. And angiographic edema is not important. Patients do not symptomatize after
Yes.
cataract surgery.
Yes.
So what's important is the
Clinical,
symptomatic
yes.
clinical cystoid edema. And you have mentioned also that the basic treatment is non-steroidal anti-inflammatories with steroid drops. For how long should we maintain the treatment?
Actually, I maintain the patient. I start the drops only 4 or 5 days prior to surgery. I continue it for 1 month at least post cataract surgery, and in high risk patients, I may extend this up to 3 months.
Some people are talking about treatment which should persist up to 4 months after surgery. However, for routine cataract surgery, you start non-steroidal anti-inflammatory drops before the surgery.
Definitely.
4 to 5 days before the surgery.
Definitely.
So about the use of Ozurdex implants in patients having this problem, when should you resort to inject intravitreal implants for those cases of cystoid maculopathy?
Actually, it is written in the literature, but in my clinical practice, I didn't face a condition which is very resistant that I'm going to use Oziodex implant. I don't know whether in your hands, Dr. Magdi, you've
most
tried.
Most of the cases, if properly diagnosed, they respond to topical treatment cases, but however, for such a long period. Any question for Dr. Usam?
Dr. Tari, I have a question. If we have a case of diabetic macular edema preoperatively, and you go for drying the macula before going to cataract surgery, and post-cataract surgery you have post-cataract cystoid macular edema, should we consider it a pseudophakic cystoid macular edema? Irving gas, should we wait for topical treatment for 2 to 3 months, or we go for intravitreal anti-VEGF?
Definitely no. This patient is from the start is a diabetic macular edema, and the cataract event increases the incidence of the cystoid macular edema. So he's treated as a diabetic macular edema.
Even he has a complete dry macula before cataract surgery.
Even if he has a complete dry macula from the start, because the disease, we know that the disease is fluctuating. It's going to be dry and
we should consider it recurrent edema. We should inject.
Definitely.
Any clues to differentiate pseudophakic cystoid maculopathy from diabetic macular edema clinically?
Definitely, in the OCT picture, you may find hyperreflective foci. You may find exudates which is not present at the pseudophakic macular edema, and the hallmark in diagnosing Irving gas syndrome is the hot disk, and you're not confronted with that hot disk in diabetic macular edema.
The question by other way,
yes.
if you have a case with no diabetic macular edema, diabetic patient with no diabetic macular edema but background diabetic retinopathy such as none or mild non-proliferative with dry macula preoperatively, and he developed edema after cataract in this eye and the other eye is completely dry, we should consider it a DME or waiting for treating it as Irving gas syndrome?
Yes, so I depend on Irving gas syndrome on the clinical picture, on the fluorescein angiographic features. So if I find fluorescein angiographic features suggesting Irving gas syndrome, so I'm going to treat it as Irving gas syndrome. If it is not, I'm going to treat it as a diabetic macular edema.
Thank you very much,
You're
Dr.
welcome, sir.
Thank you very much.